feel my body's mutilated, or, the medications themselves make me really not want to have intercourse. Or I don't know why I don't want to have intercourse, but since my breast cancer therapy, I don't want to. And then having that ability to pull it out of our provider heads and say, yeah, because chemotherapy actually can affect our drive, and there are ways that we can counteract that healthfully. So we want to be able to understand the health implications of good sexual health overall. Be familiar with how to screen for sexual health wellness. This was harder to find than one would imagine. I thought, okay, I'm just going to look up sexual health questionnaire or survey or guidelines, and it just there's nowhere. It's nowhere to find. So it was actually kind of challenging. So I put a few examples in here for you guys. And become comfortable with discussing health outcomes of positive sexual health with our patients. Because I think if we don't bring it up, it is going to be very uncomfortable for them to bring up. I think most male patients will bring up an issue of eating, but I've had very few men actually come forth with a lack of desire, like just a poor libido. It's almost like a sense of shame, like it's assumed that we should have good libido if you're a man. And so now if I say it, it's somehow a failure on his part. And so to be able to open that door, okay, do you have any problems with performance, completion, arousal, desire, right? So it's very cut and dry, just like, do you smoke? Do you use alcohol? Do you use drugs? No judgment here. I'm just gathering information. Okay, so what is the sexual health definition by the WHO, World Health Organization, which we can take or leave sometimes. I know we all have our opinions about the WHO, but it's as good a place to start as any. So it's a state of physical, emotional, mental, and social well-being in relation to sexuality. It is not merely the absence of disease, dysfunction, or infirmity. And this really speaks to my particular mode of practice, as are most of my colleagues here in this forum, is that we're not just looking for diabetes control. I want to prevent diabetes from ever happening. We're not just treating hypertension. I want to know, why do you have hypertension? How do we alleviate the inflammation that got us there, right? So that whole health has more to do than just absence of disease. So that's a really important concept in general. I was kind of proud of the WHO for coming out with that. So again, that practice gap, which I sort of alluded to, is most sexual health surveys revolve around: what is your disease risk? What are your behaviors? Do you have multiple partners? Are you using, barrier protection? What's your pregnancy prevention? What's your birth control method? And it's really interesting as I've come into this more holistic, integrative view, and ironically, as I'm in my post-reproductive years now, the push towards preventing, avoiding pregnancy, birth control pills, hormonal management, rather than a celebration of us as vessels to be able to create life, and certainly to manipulate that if it's not our appropriate timing or financial or schooling or relationship wise or whatever. Like, I think that that's obviously within anybody's right to do, but there's very little in the way of like actually celebrating the development of families. Just interesting side note there. And then it also talks about orientation and identity. So how do you identify, and what are your pronouns, and this kind of thing. And again, those things I think are important, but it's not really answering the questions regarding sexual health, such as sexual desire, arousal, pleasure, satisfaction. And again, that ability to have a relationship with somebody as opposed to just casual sex. Which I was in another forum, I think it was A4M, and they said if you just have casual sex, you actually have better longevity than if you've never had casual sex with a stranger. I don't know. I haven't independently looked up that fact, but you can take that as you will. So the aspects for consideration for female, again, is the relationship. Are we in a healthy space? Do I even like this guy anymore? Particularly my specialty, again, is more on these post-reproductive years. It comes to a point where we're becoming empty nesters. Our children are maybe becoming more independent. And now we're looking back across the coffee table at this guy, and I'm like, dude, who are you? Like, when did you pick up golf? I don't even know what you like anymore. He doesn't know what I like, because we've been so busy running kids to and from volleyball practice and paying the light bill that we haven't paid attention to how we changed. When did you get that promotion again? So I think it is important to really actively manipulate that relationship and work on that relationship independent of having a family or raising parents, right? A lot of us have our parents move in with us and we have to worry about their health issues and so forth. But taking separate time to build that relationship is so critical. Desire and libido is another faction altogether. Arousal. So I might want it, but then if I can't get these tissues lubricated, or it's raw and hurting and tearing. It's just uncomfortable. Like that will kill a mood so quickly. The ability to have orgasm. And interestingly enough, if you get into asking enough women, you'll find some that actually have gone their entire existence and never reached a climax. And so is there something precluding them from that? Had they gone through a difficult abusive situation as a child, some kind of assault? I think the last time I looked at statistics, upwards of 1 in 4 to 1 in 5 women have had some form of sexual assault. The statistics are terrible. And yet we overlook this in our practice all the time. We're more worried, are you a never smoker? Have you had your mammogram, right? We're not talking about these things. And then pain-free activity, right? If I want this thing, it has to be without pain. So I do not put my hand in the flame on my stove because that hurts. So I have an aversion to doing that thing because it hurts me. And so this can set up a psychological pathway where then I also just don't desire because I know if I do said thing, it freaking hurts. I tear, I'm bleeding, I get a bladder infection. Absolutely not, sir. It's a random Tuesday. You're on your own. I'm going to bed, right? So we have to consider those things as well. Okay. And then males, relationship. What is their relationship status? And even if they're like single and ready to mingle, that's okay. Are they in healthful, engaging relationships and conversations with their partners and so forth? Doesn't have to be a lifelong marriage necessarily. That's true for either men or women, obviously. So even if they're 20 years old and everybody's dating, like that's great. You still want to be in healthful, non-abusive, consensual relationships. And that goes true for men as well, right? Men can be in abusive relationships also. Desire, again, that libido, ask the question. That's not just about firmness and duration. It's about do you desire? And then that climax ejaculation. So I have one gentleman who unfortunately just feels like he's just completing way too soon. And then it comes back to that conversation to have with the partner. But does she think you're completing too soon? Because again, in my experience, a lot of men feel like they need to go for 3 hours, and we ladies are typically done in about 15 minutes. We're tired. We got to work tomorrow, so dog needs to be fed. There's things going on. So again, the perception of what my performance is or where I should be or what's normal may vary from couple to couple or relationship to relationship. Okay, so this is an interesting perspective. Health conditions that can affect sexual health. I think a lot of us sort of know this intrinsically, but again, don't necessarily make that association. But obviously, heart conditions, blood pressure issues, sleep apnea is huge, especially for men. It will lead to erectile dysfunction. So if any man comes in and has erectile dysfunction, immediately ask if they snore, if they've had a sleep evaluation. We work with a company out here in SoCal that does home sleep studies. I think that that's a huge benefit than going to a sleep center, taking your blankie and your teddy bear and hoping you get a reasonable night's sleep, as opposed to like, hey, it's just a normal Thursday, throw on the monitors, and then they get the data. I think it's much more true to life, obviously. Diabetes, obviously, can be a real problem with neuropathy, with vascular dysfunction. Again, not feeling good about our bodies and so forth. We get highs and lows of those sugar, which can make us irritable. So there's a lot of difficulty with diabetes. Absolutely. Any kind of neurological disease or neurological diseases, mental health disorders, obviously menopause, and then a cancer diagnosis. We're scared. Our cortisol levels are all wacky. We're in fight or flight. We're in survival mode for sure. Like if we're in survival mode, we are not also in rest, nest, and sex, right? You can't be in those two spaces at the same time. So cancer diagnosis can definitely affect our sexual health and desire. Oh my gosh, my partner doesn't want me anymore because I have this diagnosis. So then there's a lot of self-doubt and psychological aspect, as well as whatever the procedures were. Again, if you've had cervical cancer and vaginal radiation, that's a big deal, and that's changing anatomy. So there can be a number of factors that are going into aside from just, oh, I feel bad about myself because I have cancer. It's way more physical than that for sure. Medications that affect sexual health. Again, I think this is something that somewhere we learned in second year medical school pharmacology, but don't really piece together or counsel our patients appropriately when we're prescribing them. So I prescribe propranolol, I wouldn't say on a regular basis, but I'd say 2-3 times a year just for my patients who get sweaty hands. They don't want to do a ton of Botox injections there. So they're like, hey, what can I use? Or my speakers, right? My public speakers who have a little bit of stage fright or anxiety before they go on. Beta blocker is a fantastic tool. anxiety before a plane flight, great, take 10 of propranolol. But it may affect your sexual health, right? It could bottom out your blood pressure to a point that you don't have effective engorgement of those tissues. Diuretics, opioids, prostate medications, statins is a huge one. It's one of the number one prescribed medications in the United States. Again, we can have whatever opinions in our integrative space about statins, but the reality is they are largely prescribed, and that can affect patients' sexual health. Anti-epileptics, and I don't know what y'all's experience is with seizure medications, but it really changes how people synapse, piecing words together, the fluidity of their language. It really affects them in a number of ways. And so it's not surprising that it can also affect sexual health. H2 blockers, that one surprised me. I don't know what the mechanism is, but it can affect. Chemotherapeutic agents, again, can cause their own neuropathies. They can cause their own issues just because of the chemicals that are being used. A lot of them are heavy metal based. So that can really make a difference. And then again, SSRIs, SNRIs, some of the most commonly prescribed medications out there have a huge effect on libido, and it's under counseled to patients. I'm not going to sit here and say that Lexapro maybe doesn't have a role, or, some of the other SSRIs. They can help patients who need those medications, but I think it's reasonable to say, well, now I'm a happier human, but I don't want to have sex with my partner. What's wrong with me? And so when we can come back to it and say, well, this medication, preemptively even saying, hey, this can affect our sex drive, then we can make more educated decisions about which medication to choose. Well, Butrin, however, is one of our atypical antidepressants. It does not affect libido as significantly. So that's one that can maybe be an alternative for the appropriate patient. Antipsychotics and benzos. And I'm sure there's a litany of others, right? Muscle relaxants and sleep agents and whatnot for obvious reasons. Okay, but then conversely, right? If we just have a good, healthful sex life, if we've got good drive and good desire, good climax, like we're satisfied with our sex life, we actually can improve cardiovascular health, improve diabetes, morbidity, and mortality. So we're not losing kidneys, we're not losing toes, and we're not losing our lives because we had better sexual health. Mental health prognosis, patients do better who have depression, anxiety, and even psychosis types of diagnoses when they have a better sexual health. Cognitive functioning, and an overall sense of well-being and quality of life, which again, I think as the traditional providers, we tend to overlook that overall quality of life, right? We get all excited that we made this diagnosis, we gave this right medication, yes, I won. And then we forget that they were on 20 more medications, expensive to them. They can't get to the pharmacy unless their son takes them. Like so many things that even though we got it right, we don't get it right because those patients don't have a residual quality of life. That's what we're being here for. So again, that quality of life is kind of an objective and subjective measure. There are surveys that you can do for assessing quality of life if you want to be super academic about it, which I don't think is a bad thing. I just am too disorganized to be able to handle that. But it's a physical sense of well-being, emotional, mental, material, social, right? We're social beings, and safety, resources, living conditions. Again, if I'm in a physically abusive relationship, if I'm living under a freeway overpass and there are 16 other homeless people here who have weapons, no, I don't have great quality of life, and I probably don't have great sexual health here. And if I do have any sexual encounters, they may actually be predatory. So it's important to kind of dive into some of these more uncomfortable topics that we sort of think about being on the other side of wherever we are, right? If I'm in California, it must be happening in West Virginia. And if I'm in North Carolina, it's got to be happening in Iowa. It's not here, but it is happening just right around us in our own community. So important to kind of tap into some of that and make it a safe space for patients to discuss, for sure. All right. Sexual health and quality of life are integrally related, with each affecting the other. So again, the converse is true, right? Good sexual health means good quality of life. Good quality of life, usually then we're going to feel better about jumping into bed with our partner. It's like, yeah, babe, you got the bonus, mortgage is paid, kids are on bed, everything's good, everybody's healthy today. But if I'm running crazy and my kid's got the flu and she's vomiting, 14 times a day, I got to go sit in chalk ER. Like, nobody's having sex. We're not talking about that right now, right? So they do affect each other. And so again, here's what I was kind of alluding to is, well, I don't have a lot of desire or enjoy sex. I feel badly for my husband, said every woman in perimenopause or menopause. And we have to kind of take back our own health and our own normalcy. It is normal to desire sex. It's normal to want that arousal. It's normal to want climax and to be healthy and safe in that relationship and satisfied. So it's not about the other guy. It's not about the other partner. It's about your own health and understanding how that understanding of sexual health tells me that I'm actually in a state of whole health. Okay, busy slides, guys. Here we go. So sexual and physical health, particularly for the female, this particular study that I have referenced at the end went into some female health, male health, heterosexual relationships, homosexual relationships, normal aged adults, older adults. Like I think they did a pretty whole job. It was a meta-analysis. And sadly, I think they looked at like 20,000 studies that were all smattering out there. And then when they kind of filtered it down of what they actually wanted, there were like 63 studies. And so again, it's very sobering that we think there's all this research out here in this realm, but they're kind of not, so it's a really important aspect that we need to build. So female sexual function positively correlated to psychological, environmental, social, and overall quality of life. Female sexual function linked to health status and physical and psych components. The same was true also for pregnancy, but there was an interesting one. I don't know if I put it in here. For sexual frequency, they found that was not additive for good quality of life in the postpartum period. I'm like, wow, we need like a whole study to say that out loud, that if my bottom undercarriage is torn up with stitches in place, I'm still bleeding lochia, I'm leaking breast milk everywhere, and I've been up every 2 hours cluster feeding this child, that I actually don't want more frequent intercourse. Are you kidding me? Like, I don't know why we had to write that down in a study, but somebody did. So I'm excited that we at least have that data. So again, if you've got a postpartum woman coming in and she's like, girl, I don't want sex with this man ever again. In fact, if he never touches me again, I'm perfectly happy. There are reasons why, and it's pretty common for those, physical barriers to being able to enjoy that component. Also, when we deliver that placenta, we lose that massive amount of progesterone and estradiol that pregnancy was holding. So we go into this relative abrupt menopause. Again, nobody taught me this. This just came from years of being an obstetrician, and these women are coming in, they're having hot flashes and they're having vaginal dryness, and they're night sweats, and they're just waking up drenched, before they're even leaking milk. They're just horribly sweaty. And it's like, what the heck is happening? It's like, well, their estradiol levels were in the thousands, and now they've dropped down to like 40. And again, if you're still breastfeeding, your estradiol levels will continue to be suppressed, so you can continue to make milk. So yeah, you don't feel great at all. You feel like a 25-year-old menopausal woman, and it's actually miserable. So I think if we know this as providers, we can then better counsel and foster our young women in as they're becoming parents and saying, hey, a lot of these changes are normal. They are temporary. There's nothing wrong with you. And you can augment with a bit of vaginal estradiol. You can do a little topical estradiol, like transdermal estrogen. There are ways that you can actually navigate that time period for women to make them come back to more normalcy sooner. A decline in sexual function was associated with more menopausal symptoms. So again, that converse. So of course, if I have a lot of menopausal symptoms, I don't want to have sex. But actually, if I'm just not having a great sex life, I'm going to have more menopausal symptoms. So I think that we have to think about it bidirectionally. Postmenopausal sexual desire was linked to greater vitality. So we just, oh my gosh, the typos. I'm so sorry. That's really important as well, because a lot of us feel like this decline during menopausal years, and this is an area where we can actually help offset some of that decline. Arousal and orgasm are linked to lower experience of physical pain. Sorry, I'm glitching. I don't even know if I'm having a stroke over here, so I apologize for the stuttering. But again, our physical pain is better when we have that release of that oxytocin and our epinephrine and norepinephrine, all our beautiful neurotransmitters that tell us that we're loved and we're whole and this was a great experience. Then yeah, the physical pain receptors are not firing at that moment. So it's a really cool correlation. And then women in same or mixed sex relationships with good sexual satisfaction had fewer physical symptoms and better overall health. So again, looking at those relationships as well. Male sexual frequency and sexual quality of life were positively associated with overall quality of life. So when men are having sex, they feel better quality of life, right? So that's good. And again, it seems very obvious, but I think when we're able to counsel our patients that this is an obvious statement. So where do you stand on this, on this kind of continuum, and help them feel okay and safe to discuss. ED and orgasmic difficulties were associated with lower quality of life. Again, if I feel like I can't perform for my partner, I'm not climaxing, I can't finish, it's an exercise in futility, then yeah, they're going to feel kind of that sense of failure and I'm not enough, right? So again, opens that door for a conversation about what is their biochemistry doing, what are some other factors. Increased satisfaction, sexual satisfaction is associated with increased quality of life at older age. Again, a statistic that I think we often forget is some of the highest transmission rates of sexually transmitted infections are in our senior population in assisted living facilities. And it's usually like an 8-to-1 ratio of women to men. So those men are just visiting from one nice young widow to another nice young widow, and they're living their best lives. And they're transmitting gonorrhea and chlamydia and HIV and HSV and everything else. So it is important to ask even our senior patients, where are we at with sexual satisfaction? And some of them, quite honestly, their relationship has morphed into such that they have a very amiable companionship. Maybe she's got diabetes and he's got heart disease. And so cardiologist and endocrinologist has said, hey, maybe sex isn't the best thing. Okay, but they're perfectly happy. They're in a satisfactory relationship. They have that intimacy and vulnerability that may not be from orgasmic penetrating intercourse per se, but still important to check in on what that relationship looks like for sure. Men with increased sexual health had a higher health-related quality of life, so again, more physical symptoms, and then sexual satisfaction was associated with better vitality. Okay, sexual function and health promoting lifestyles showed health behaviors were correlated positively with sexual function domains. Now, some of the wording on these things is something else. But what it's basically saying is if we're eating well, we're hydrating well, we're exercising regularly, we feel good about the person we see in the mirror, and we're doing these things for strength training, muscle mass, bone density, it is also going to contribute to our overall sexual health. Not just because we see something that we like in the mirror, right? Like we may never look like we did when we were 15, and some of us don't want to, the acne. But that said, though, it still leads to better quality of sexual health. So that's a good thing. All right. Okay. Sexual and psychological health. So kind of getting more into the psych realm of things. Sexual satisfaction was correlated with vitality, and that was for both genders. Higher sexual function was associated with fewer psych symptoms and higher psychological functioning. Okay. So again, if you have anxiety, depression, bipolar disorder, schizophrenia, individuals who had a feeling of like higher sexual functioning actually did better in general with those ailments. Women's sexual arousal had negative correlation with depression. Okay, so again, the wording in these studies, it's saying basically like better sexual arousal, fewer depression symptoms, right? So it's an inverse proportionality. Same thing with orgasmic function for anxiety and depression. Postmenopausal women, positive correlation between overall sexual function, sexual desire, and overall psychological health. If you were in my talk last time, we kind of discussed how menopause makes changes to the brain. We lose white matter, we lose gray matter, we lose our ability to cope. We are far more irritable. So things we used to put up with, like the socks on the floor and the dishes in the sink, it's like, oh my gosh, it's not my deal, whatever. I love my family. And now it's like, are you guys kidding me? Like the level of disrespect for you to leave this for me to do, right? So we don't have that ability and that filter anymore. And so it is a very biochemical, neurochemical transition that happens in these perimenopausal, postmenopausal years. But when we have overall good sexual health, we'll have overall better psychological health. We'll be able to have better coping, toleration, and so forth. Tolerance of our families. Who we love so much, actually. Men, that sexual dysfunction correlates more with depression. And it's a chicken and egg thing, right? Do I feel poorly? Am I depressed because I don't have great sexual function and I'm not performing for my partner and I can't get in a relationship, etc.? Or is it because of the depression that I don't have good sexual function? Like my boy's not working. I don't have the arousal. And again, we know of that phenomenon, anhedonia, with depression, that we just don't want to do anything that's fun. So even if you love golfing, now you don't want to golf. I don't want to go boating. It's too much work. I'll just sit right here on this couch and grow roots. And that goes for sex as well. Like if I have high depression symptoms, I may have no desire for sex because nothing that's even fun for me normally is seeming fun. Adults and older adults, reduced intercourse frequency correlated with more psychiatric issues. And it was a curvilinear pattern with the sexual frequency. They found there was not a huge benefit beyond once a week. So at least that's a target you can say for your patients, like, hey, just have a date night once a week. Try to get in intercourse maybe once a week, but you don't have to be like rabbits 3, 4 times a day for God's sake. But, once a week is probably plenty. Increased sexual frequency, again, associated with higher sense of well-being, but not greater than once a week. Sexual satisfaction was inversely linked to psychiatric symptoms in hetero or homosexual relationships. Older women, sexual satisfaction had a negative correlation with depression and anxiety. So again, women feel better if they've got better sexual satisfaction, don't have as many depression, anxiety symptoms. In couples, women's sexual satisfaction was negatively associated with depression and the partner's depression scores. So even just let's say it's a heterosexual relationship, my wife is happy, I have less depression. I did that, right? So even the men in those partner relationships had fewer depression symptoms and lower scores when their woman was happy. So that's interesting as well. Our health plays off each other. And then men, their satisfaction had a negative correlation to anxiety specifically. So that's interesting. So again, is it the oxytocin that's released? Is it the calming hormones, neurotransmitters that maybe have something to do with it? I don't know. It didn't say in the study. Life satisfaction and well-being were correlated with sexual health. And then married women, that sexual quality of life was associated positively with happiness and life satisfaction. So when I'm feeling good in the bedroom, I'm feeling pretty damn good about all of it. We got to wait half an hour at Olive Garden before we get seated. I don't care. I'm good. Everything's good, right? So we just have a better sense of happiness when we're satisfied. Okay, so here's a couple of surveys if you want to grab these guys, snip them out. This is very easy. It's just 5 questions, right? Because the last thing we need is one more goddamn survey when you're doing PRP and we're doing stem cells and we're doing estradiol patches and what's your family history? And again, are you a never smoker trying to get any insurance reimbursement, which thankfully I don't have to do. But just 5 quick questions and it's just opening the conversation. Are you having any difficulties with your sex life? That's very vague. Compared to the details that we just talked about, that's super vague. But if they're answering yes, tell me about that. Like, what does that look like for you? What do you mean? Well, my wife hasn't had sex with me in 3 months. She sleeps in the other room because I snore. Wait, you snore? So again, opening the door that maybe we need to be doing a sleep study and so forth. So it can really give us insight into what else is happening, right? Do you have any questions and so forth? So this is a pretty good, very basic tool. Here's one that's a little bit more in detail. Again, if you're a research type person or you just love data, these are really cool. It gives you a scale 1 through 5. You answer each of these questions. Honestly, I feel like I'm back at first step boards with a 17-1 and then I've got 1 through 5. Like I've got to do math. Absolutely not. But I put it in here for completeness sake. And then here's a couple of other indexes that you can look up. Again, I had a little bit of a hard time finding a PDF or a good printable resource. I'm sure it's something that anybody's office staff or yourself individually could retype, just if you get the actual questionnaire. But again, just there are tools available. This has been done. You don't have to reinvent the wheel, which is nice. Okay, so other factors affecting sexual health. Chronic disease. I don't feel good. There's a study that I always laugh at. I think it was out of Harvard, and this was really close to when I was in medical school. So I went to medical school with dinosaurs, actually. So it's been several thousand years. But they had a study that showed that if you have chronic pain, you're more likely to have depression. Well, yeah, if I wake up every day and my pain scale is 6 to 7 out of 10, and I know there's no way out, I'm always going to feel this way. I'm never going to get any better. I'm depressed just thinking about it, and I don't even have those symptoms. So it's like so silly that we're putting like dollars of funding behind these things to state the obvious. Hey, the air is good for you. You should breathe on a regular basis. But chronic diseases do affect sexual health because either from a vascular standpoint, a neurologic standpoint, or just an overall sense of well-being. I don't feel good today, babe. I'm just super nauseous. I can't even lay flat without wanting to vomit. I can't. Fibromyalgia. God, just don't touch everything you touch me is just hurting. I'm not wanting to have sex. If every place you touch me, I have a trigger point. So, really having an empathy for these patients who are going through chronic disease, understanding that that is a very typical correlation to their sexual health. It may affect their sexual health, and that there are ways to get through it and improve. Socioeconomic adjustments, right? So if you've gone from living in a beautiful 4 bedroom, 3 bath, 2 story, whatever pool spa, and now you're in a 1 bedroom apartment because of some horrible financial disaster. I mean, think about the fires in the Palisades and everybody in North Carolina that got decimated by, the hurricanes and, East Tennessee and so forth. Yeah, again, not wanting to have sex when I don't know how we're going to cook. I don't even have a stove. What are you talking about? Right. So when we have these other life stressors that put us into a fight or flight state, we are not rest, nest, digest, sex, right? Being in a consensual, healthy relationship can impair our sexual health. If we are not in a good, healthful, supportive, consensual relationship, I think those of us who are in a really healthy relationship, we kind of forget the fact that there are some very, very unhealthy relationships out there. There can be manipulative individuals and abusive individuals and non-consenting. There's sex trafficking everywhere around us. Again, these things are happening in our communities as much as we'd like to believe that they're not. So important to try to work those questions into the conversation. And then conversely, sexual health can affect chronic health conditions. So when we have good sexual health, we see better cardiovascular outcomes and so forth, better psychological improvements, better emotional health, ability to cope, make social connections, and overall quality of life. Okay, so how do we help, right? This is all fascinating, but then what, right? So the basics, right? Go back to lifestyle changes. These things can do immense benefits for our sexual health. Again, not just because we look in the mirror and I feel like my biceps look fantastic, right? But girl, I'm working on my shoulders. They're looking good. Not gonna lie. But aside from that, it's that I feel stronger. I feel more vital. We're building testosterone and DHEA when we're working out and lifting heavy. Um, I put hormone replacement therapy under lifestyle and natural things that we can do because you're really only replaced for women. You're replacing the thing that our ovaries no longer produce because we are no longer reproducing. So it's helpful for maintaining that tissue integrity overall. And it's going to help prevent injury when we are exercising. It's going to help prevent abdominal adiposity. So there's a number of things that HRT helps with aside from hot flashes and night sweats. Quit smoking. It leads to vascular disease and you're going to have erectile issues, right? Plus you smell bad. You just stink. So stop, right? Not to say I haven't had a cigarette here and there, but just in general, we want to avoid that activity. Alcohol as well. It leads to suppression of sexual drive, makes us snore more, which again leads to more ED and other sexual dysfunction. It's inflammatory in general, and it really prevents arousal and climax. It delays those things. So again, if you're an early arriver, if you will, like early ejaculant, then maybe a little bit of alcohol might help to delay that a bit, but I wouldn't use that on the regular because it is a very toxic tool. Obviously, illicit drug use, and then do some stress management. I oftentimes tell, particularly mom, I have mostly women in my practice, but I do have about 20, 25% on men. But for my moms, it's like, don't sign up to be PTA president and you don't need to be team mom and sew the banner from scratch after you've woven the fabric. Like, stop volunteering. Now, if you want to participate in the church potluck, go bring a dish, but you don't have to organize, right? And a lot of us, especially when we're type A, we're like, well, if I want it done, I'll do it myself and I can get it. I can do it. Just because you can doesn't mean you should. There's a lot of yard work I could do, but I don't want to do that anymore. So I pay people, right? So it's a matter of understanding how you can eliminate some stressors. If your mother-in-law is super caustic, stop going over to visit. Or make a deal with your partner. I'll go visit her once a month, but we're not spending every weekend over there. At least I'm not. You want to go, by all means, I will stay here with my crafts and hobbies, right? So building those boundaries out that I don't need to go and be in a stressful, argumentative encounter with somebody maybe you like, but I don't like. You go ahead, but I'm not going to hang out with those friends anymore because I don't feel great when I do. And that's going to give you some less stress in your life. We can't avoid all of them, right? We still have the mortgage on the first of the month and the kid crashed the car. And like those things are just normal life, of course. But when we can eliminate certain things, do that. Counseling. And again, either couples counseling, individual counseling, sex therapy specifically, that can really help. And again, especially in our empty nesting, kids are more independent years, reconnecting. And even if it is in a counselor's couch, to say this is our dedicated time on Tuesdays at 2 p.m. is our time that we're connecting. And then eventually you can graduate from that counseling and get to lunch at 2 p.m. And then you're in bed at 2 p.m. and having a nooner. So it definitely can grow from there. But if you're just dedicating that time to one another, where again, previously it's like, who's making dinner? I'm taking kid to volleyball. We're over here, we're over there. We just had volleyball tryouts this last week, and it's been a night. No sex was happening as we were doing volleyball. Oh my God. Planned intercourse. Map it out. Put a different schedule. Christ, we put everything else in there, right? So we've got Bible study and we've got all the things and the PTA meeting and the back to school night. And so, yes, date night with partner, even if I don't leave the driveway and we just make out in the front seat, I don't care. That's fine. Have that connection time. You are important enough to me that I have penciled you in and I mean it. And you've dedicated that time to one another. I think that's really, really important. And a relationship assessment. Sometimes you just don't like the guy anymore. Like you've changed. We don't have the same likes. We don't have the same goals. We got married. My first marriage, I got married at 17. By the time we were 30, it's like, dude, I grew, you didn't. And that's okay. And he's now 52 and still living at his mom's house. And that's fine. Um, you're okay to do that. I don't need to be with you to do that. Right. So having that kind of real self-reflection. Who am I in this relationship now? Who are you in this relationship now? Are we still loving each other? Maybe if not in love anymore, and like that super wild passion, but like I really like you and I think we're great together and we have similar goals. And then you build off of that platform, right? But sometimes we lose sight of that. Sure. And then here we go, some medications, right? So HRT, yes, I said it again, it is that important. It's really, really an important tool for us to be able to use both men and women. There are so many endocrine disruptors, and God bless RFK. I hope he can get a lot more work done with the FDA, with medications, and with environmental pathogens and hormones and what the hell's in our water and chemtrails. Again, pick a rabbit hole, right? It's not to get political. It's just the reality is we are inundated with things that affect our hormonal health. I think we oftentimes forget that they are named sex hormones because they are made in the sex organs, but have benefit around our entire bodies. Just as thyroid hormone is named because it is built in the thyroid, but has receptors in our whole bodies. So we understand that about thyroid. We understand that about insulin, but we don't understand that about sex hormones globally as providers. So we need to start making that understanding is that, yes, hormone replacement therapy, good for sexual health, but also good for overall whole health. Viagra, Cialis, right? I mean, if we're like, we love that human that we've partnered up with, again, hetero or homosexual relationship, doesn't matter. Love that person, but I don't have the firmness. I don't have the duration that I need. I can't get the job done. Okay, then use these tools, right? When safe to do so, make sure that you've screened them appropriately for heart disease and so forth, and the headache that could follow and whatnot. But definitely a tool. Lubricants, no shame in that. Again, if the issue is friction, tearing, rubbing, irritation, lubricants can be really, really cool. Peptides, these are really great, particularly for my young men who maybe have a testosterone insufficiency, but want to maintain.
House, and now Lewis is going to Katya's house. So
I
is
think
it?
it's just interference. But want to maintain
Yeah, no,
fertility,
yeah,
right? So they want to maintain sperm
Okay.
production. Then kisspeptin and
Well,
melanotan can be really, really cool
Basin.
tools.
of course.
So something to explore if you
And my
haven't.
my phone.
And then, again, exploring different things. Again, what you liked when you were 25 and newly married, you may not like now. So little sexual exploration, tools, devices, toys, literature, what they call now, there's a new phrase, cliterature, right? So kind of our smutty romance novels. No shame in that. visual, like whatever we need to kind of build on that relationship. And I think doing that with your partner instead of sort of sneaking away into the back room and doing these things on your own, but saying, no, you can be part of this. Like this is part of the fun, right? Part of the fun of being in a new relationship is the pursuit and dating and oh my gosh, did he ask me out again? And all of these fun aspects, we sort of lose that when you're sort of expected. I mean, same guy keeps showing up every night. I guess he's staying. And so we lose some of that desire and drive and like that excitement. And so bringing some of that back into your relationship, I don't think there's any harm in advising your patients. Now, again, advising our patients of that when their hormones are corrected as well, right? So if the woman is tearing every time she's trying to have a relation with her husband or her partner, and you're like, girl, just read porn, like that, you're not addressing, right? And it's very dismissive and condescending. So we want to make sure that we're really addressing that whole health, but we really leave nothing off the table, right? That these things also can be very beneficial to a relationship and to having that whole sexual. There's no right or wrong answer for couples. Okay, so a little bit of discussion. It is just imperative to include this sexual health as part of their HPI, part of their review of systems. The more often you do it in your practice, the less uncomfortable it becomes, right? It's instead of like giggling like a bunch of 13-year-olds in sex ed class, it's like, no, that's just part of my intake. I mean, I ask patients all day long about water damage to their buildings. Do they have any leaks? Do they have any black mold exposure? She could be there for a total menopausal. I'm having hot flashes and night sweats and I want to kill everybody in my household. I got you. Do you have any leaks? And I will qualify that by saying, I don't think what you're going through has to do with mold. I ask all of my patients, right? So you could even follow up some sexual health questioning with, I'm not implying you're having an issue. I ask all of my patients, this is one of my normal screening questions. And then it's like, oh, okay, we'll just, of course, everybody asks it. And how's your hydration? And what are your bowel movements like? So you move on to some of these other aspects just as much as you would ask, what do you do for work? So you can figure out environmental toxic exposures. But the tools above that I listed, those couple of questionnaires can be a great segue to opening that discussion. So that then when they've already answered questions about their sexual health, you now asking a follow-up question is not out of turn. It's like, well, of course, I mean, I just filled out a damn survey about it, just like I filled out my medication list. Like, how long have you been on the statin? How long have you had diabetes? Okay, you said you don't have sexual satisfaction. When did that start? How long has it been going on, etc. And the more comfortable, again, you are discussing sexual health, safer your patients will feel. And I think that there's nothing more honorable to us as providers than when a patient can feel safe to be vulnerable. So many times I have patients just apologize to me because they break down into tears. I had a gentleman, a 75-year-old gentleman. He's like, I love my wife. I have a beautiful life. I'm financially stable. Like I have everything I could possibly want. And I feel weak. I'm not sexually interested. And he started breaking down into tears. He's like, I've never told anyone, not even my wife of 45 years. So to be able to create a space where he's feeling very safe and okay to cry or to show emotion and know that the automatic knee-jerk response on my end is like, oh shit, crying, Lexapro, like here's anxiety, you need benzos, and so many women are afraid to cry in my office because they're like, great, I know she's going to think I'm depressed. She's going to think I'm a head case. And I'm just done. I'm tired. I'm frustrated. And so being able to identify those emotions, say, I know these are uncomfortable emotions. We all feel them from time to time. I understand why you're frustrated. I understand why when your body's changing, you don't feel good. And so it makes us very vulnerable. It's okay to cry here. That's all right. We're going to get you figured out. We'll make it okay. And if somewhere down the line that means a prescription for Paxil, then it means a prescription for Paxil. That's not a failure either. But for that to be the automatic response, which it is by most Western providers, can be very frustrating and daunting for our patients, for sure. So that's it. It was kind of a quick one because, again, out of like 20,000 studies, there were only 63 that actually got filtered into this. But I thought it was a lot of good, very dense information, but a lot on the same theme. So I'm hoping that this helps.
Okay, well, thank you.
Oh, you're back.
So I'm back. Yeah, I'm back. I I know you were a little hesitant to take up this topic, and sometimes we lose some participants in the in the interim, but it's a part of life, and it's part of what we all deal with, especially those of us that deal with hormones all the time. Um, and does anybody have any questions? I don't think there's a whole lot in the chat. Um, Dr. Nario, if anybody,
Yeah,
I
I
you?
have a
go ahead,
question. I would ask also, what about like doing meditation sessions or yoga or getting into higher consciousness where you can help the people's souls evolve?
Yes, yes, 100%. I think, just very centering activities. Tai Chi is another one. There's a number of things that you can do to really refocus and have that introspection, feel very grounded, get close to green things, all of that. And then again, the more you can do that with your partner, I think that it brings a mutual connection. We're sharing that energy. And I think that that's really
It's
cool.
like soul enhancement.
Oh, yeah. Yeah. hmm
Wow.
Good point. Absolutely.
Hey, can anybody hear me? John Burgess talking.
yeah, we
Yes.
hear you, John.
Hey, man, that was very cool lecture. Thank you so much, Dr. Sammons. Um, I can't make my video work and other things, but at least we're talking. I'm still on the Big Island, and I did meet with the integrative guys here. All they, let's say 90% of the discussion they had here was orgasm, and more orgasm. And it's just on their mind, big. I never heard anybody talk so much about orgasm, but they're all in that run right now. So this is very timely. And the only other thing they talked about were med beds. Are you familiar with those, Dr. Sammons?
No, what is that?
It's like a big tubey bed thing you get into that's enclosed, and they use quantum energy to restore tissues. Here they
Okay.
believe you can regrow limbs using
Wow.
this. And if you do it on Wikipedia, it'll say half conspiracy theory, half real.
Yeah.
Uh,
Is it like a
But
Rife machine, like the Rife type of frequencies or something similar?
I have no idea, but even there's a news agency that announced a bunch of information yesterday on alien spacecraft, that type of thing. I don't know if
Hmm.
you guys have heard about it, but
I didn't hear it.
within the next 12 months, they plan to release a lot of this information, even the government, because they're caught. They can't hide it anymore, right?
Yeah.
So it also deals with the quantum elements and the release of 0 point energy. There are already machines designed to create unlimited energy from 0 point. So the quantum energy, the 0 point, and the alien connection is to be released big time in the next 12 months. Most of the military information that's been, just quieted down for a long time is coming out. And the underground bases, they're going to start talking about that too. But anyway, that's all I heard here was the med beds and orgasm. So very timely.
Perfect. I have a book here called Rainbow. Oh, hell. Something about the rainbow. The Invisible Rainbow. There it is. I found it. And it talks a lot about the electromagnetic frequency, fields that we emit and so forth. And I think that it used to be understood like in the 1800s, kind of when it started. And then as we got into more of the synthetic petroleum-based medications in the 1920s, 1930s, it sort of fell out of favor, and became very like voodoo, witch doctor. This is not a real thing. So I think we really lost a lot of our understanding about our connection to Earth, our connection to EMF, our connection to one another. And it's there. I think that we just don't fully understand it. So I always say, what was snake oil 150 years ago is now common medicine, common knowledge. And then, same thing will be true 50 years from now. So I think there's a lot of
Right.
just growth to be done.
In the I was in the military world 50 years ago, And we
Thank
had
you.
all of the, and I'll say at least 20 years before I was in, we had the underground military bases that were half for human being and half for aliens. I have been in those bases. I can say that now because they're starting to release this information. But it's been known a long time, but it's been suppressed ever since oil started making money.
Yeah.
But the alien connection is really coming out now, and it's very real. And the people who have been releasing the information are the military guys. Retrieval. They've been picking up spaceship retrievals, right? Flying saucer retrievals. And I was involved in that too, also 50 years ago. But it's been absolutely suppressed, along with the other things, like you're saying, the 0 point and the quantum. But within the next year, the government plans to release a lot of this information.
Wow.
Yeah. And if you didn't know, yeah, big grays and little grays, right?
Yeah.
Big grays are the real ones. The little grays are bio robots. So what they had in the underground base where I was were the 3-footers, and that's basically my understanding bio robots. But all this will be coming out.
Wow.
All right, John.
Yeah, I'm still weird, Bill.
Yeah, well, that's okay.
Yeah, it is.
Okay. There is a question about, so we're getting a lot of praise in the chats, and there was a question here about a workup for a menopausal 70-year-old female with a history of thyroid cancer 30 years prior, a total hysterectomy. I lost
Yeah,
it. What happened?
so
Where
I
did I
just
get?
gave a little response there, but
Okay.
so I do the same hormone workup that I do for patients who are 50 and just newly menopausal, or 40-year-olds who might be
Hmm.
perimenopausal. So I'll check my estradiol, LH, FSH, progesterone, total and free testosterone, DHEAS. I like to check thyroid hormones at the same time. So I do TSH, free T4, free T3. And then you've got to follow the glucose, right? A1C, fasting
Hmm.
insulin. I like to check AST, ALT, and I didn't put that in the comment, sorry. And then
Right.
also an MTHFR and a homocysteine to see what is their methylation ability. And I think that that's a good broad first start. And
Hmm.
then we've seen that even for this individual, let's say that she's, really needing something, chronic UTIs or recurrent UTIs, vaginal estradiol pretty much universally is safe.
Hmm.
Anybody, anytime, any onset after menopause or implementation after menopause is safe to do. They're actually looking at removing the black box warnings on these products. So I usually do just a fingertip full, just a little blip, like you do toothpaste, right at the opening, once a night for 2 weeks, and then 2 nights per week thereafter, indefinitely, until I go toes up. And when I'm in my coffin, please pack my vaginal estradiol with me right next to my rosary beads. Like, I'm not leaving it at home.
Make,
So,
make make sure you leave it in the will. So
yes, exactly. Oh, it's going
leave
somewhere.
it with the instructions.
That's
Okay.
right. So you can definitely start there very, very safely. And then for other women who are in their 70s, let's say it's frozen shoulder, chronic back pain, cognitive decline, any of these other aspects, I will still feel comfortable because of my knowledge base and experience that I'm okay starting them on a little bit of Bias cream or a low dose estradiol patch, maybe 50 milligrams of progesterone. If she's had the TAH, does she need a progesterone or not? Not necessarily, but progesterone and estradiol work as very close sisters. So they do have very
They make you
symbiotic
link
benefits with one
to
another.
orgasm.
So you may want to still start her on progesterone, particularly if she's got sleep disturbances, nocturia, anxiety, night sweats, these kind of things. Progesterone can be a super huge help. And then I'm
The
really strict about
orgasm
following levels for my
connection.
patients every 3 to 6 months, depending how stable they are, because I don't want them overshot. I've been introducing more testosterone to my patients as well, my lady patients. And again, usually the dosing there is 2.5 to 5 milligrams per day. And I follow levels to make sure that their levels are somewhere between 40 to 70. We don't have to get crazy. Ladies do not need a testosterone level of 300, right? We're not men. We're not trying to be men, but it will give us a sense of vitality, mental clarity. It helps with vascular disease. It helps with muscle maintenance and muscle mass. So there's a lot of benefits to that testosterone as well. DHEA, super, super important for brain maintenance, as well as being, again, the baby brother to testosterone. So he's another little Bob the Builder. So a lot of benefits there, even if she's 70. We just want to advise her that from the existing literature, which I'm going to bitch about tomorrow, again, if you're with AASCP, I have plenty of words to say about it. Even with shitty hormones, people still do really pretty well. But there is documented as like an increased risk of cardiovascular outcomes, so heart attacks and strokes, if starting hormone replacement therapy after 10 years of the onset of menopause or over the age of 60. Now, the reason I put hormone replacement therapies in air quotes, because they're using, like in these studies, they're using oral conjugated equine estrogen and oral medroxyprogesterone acetate. So it's a progestin, and it is conjugated equine estrogens, which is muddy estrogen, right? So it's estradiol and 14 of her closest friends, neighbors, and frenemies. So these are all of these different subtypes of what should be just pure estradiol are affecting receptors very differently. And so conjugated equine estrogen is not the same as like just estradiol, right? They're not the same. And we also know through multiple studies that transdermal approach is far safer than oral approach. So you will have fewer of those cardiovascular VTE stroke events when you use a transdermal application of estradiol to an oral. And now again, tomorrow in the conversation, I'm going to talk about, there's another recent, well, not that recent, but only recent to me. It was 2016, but I only just found out about it, that the use of vaginal estradiol actually cuts down on cardiovascular and stroke mortality. So you may still have a heart attack, but you're not dying of it. All right, I'll take that for a win. Stroke, not so much. I mean, just croak it. I don't want to have a stroke. But heart attack, come back from it. It's because the vaginal estradiol is having a benefit with overall inflammation. It's reducing the amount of bacteria that can get seeded into those coronary vessels because of recurrent urinary tract infections. So it's saving lives, just if you use nothing other than vaginal estradiol. Interesting.
Yeah, I'm actually a member of the British Menopause Society, believe it, of all things.
Nice.
And,
Okay.
and it's rather interesting the contrast. They hold that any female over the age of 60, no hormones at all, and the rationale is that it's according to them, not a question that cardiovascular disease is increased with the use of estradiol, or well, they say estrogen, so I'm sure that it's equine estrogen, and progesterone is rarely ever prescribed. It's not, not available on the National Health Service formulary.
And it's tough to weed through the literature because they use progestin, progesterone, and progestogens
all the same.
It's all the same. And so even if you're really actively trying to educate yourself and you're reading the literature, they don't delineate what the chemical structures differences are. And so you really have to have a passion and a drive to dig into that, or have somebody just point blank tell you they are not the same thing. So medroxyprogesterone acetate is not progesterone.
Right. It was the same here 15 years ago when I started doing this. But it's been cleaned up some since. If I just may add to your workup, I always do an estrone level, and we do vitamin D, D3, 25 hydroxy vitamin D3. We get a pregnenolone level and a prolactin, and a sex hormone binding globulin. So, and I always get for everybody at least once. I get the thyroid antibodies.
I like my thyroid oxidase antibodies.
I'm not sure where you are, but where I live, it's like an epidemic around here. And I'd say at least a third of the patients who come to me, new patients come to me, have positive thyroid antibodies and don't know it.
Even if they don't have overt thyroid failure yet, it's a big indicator. And if you're going that far, then I would also check a vitamin D, because if you've got low vitamin D, you're going to have higher thyroid peroxidase antibodies if that is an issue.
Right. And then, if they do have positive thyroid antibodies, there's a precious few who know what to do with it. They just say, well, there's nothing you can do about it. So
Then you do,
that's a
yeah, so they don't check.
that's a whole nother lecture. So
For sure, for sure. But
so
also, if you guys are curious, like a shameless plug, I've put together a menopause seminar for individuals who are maybe new to hormone replacement therapy. You're scared of it. You don't really know how to follow levels or what normal levels look like or how to prescribe. Like, it literally goes into the nitty-gritty of actually how to write a prescription for these things, how to make a relationship with a compounding pharmacist, and so forth. So I do have that on our website. Please give us a follow at Transformation Health Today on Instagram. I'm trying to get up to 5,000 followers this year. It doesn't mean anything, like I don't get paid for it, but it's just fun. It's a nice goal. And then I'll be speaking at something called the Fit Expo with Aesthetic Immersion this weekend at Anaheim Convention Center. So if anybody's local, I'm going to be speaking to a very similar topic, and it's an open panel question and answers as well with another provider who specializes in sexual health and well-being. So it should be a really cool adventure. And then we're going to be out in Vegas in November.
okay, great. High TPO. Somebody asked about a high TPO, so I don't know if we want to get into that tonight. Do you have any you want to tackle that one? I mean, that's a whole 2 hour. That's a whole
Yeah,
2 hour
to me,
lecture.
I simplify things because I'm not that bright. So I like to just make it super simple. Give
Mhm.
vitamin D. So when we can get their vitamin D serum levels optimized to about 80 to 100, you will see those thyroid peroxidase antibodies come down. And there's
Mhm.
multiple studies that demonstrate that. I'm sure there are other ways to do it as well. I've heard vitamin C, E, A, like there's a number of other things, but I keep it simple. I tell my patients all
Mhm.
the time, I'm a directed minimalist. I'm going to tell you which things you should take, but I'm going to try to keep that a very streamlined regimen, because the more complex we make it, the harder it is to sustain. It gets
Mhm.
expensive, it's convoluted. Fix their vitamin D. Get out in the sun, take a vitamin D supplement, particularly if you're not living on the equator and you're not naked in the yard for 3 hours a day. You need to be on a vitamin D supplement. So I go back and forth. I've been doing 50,000 per week for like a while, all the way from COVID, because then you can do a vitamin D hammer with any viral illness of like 50,000 per day for 3 days straight. The
Mhm.
beautiful antiviral regimen. But I've been going back more to like the 5,000 a day, and I'm seeing better serum responses to that, interestingly.
Mhm. Well,
Um,
we usually look at it for every 1,000 units of vitamin D. The blood level should go up by about 8 points. That's a pretty good rule of thumb.
in how
So
long?
five
Like how
thousand
often do you
five.
check?
What was that?
How soon after would you recheck?
Oh, we're kind of busy, so ideally we like to check in 6 weeks, but it's usually 3 to 4 months.
3 months.
So
Yeah, that's about what
yeah,
I do. I'm like, let's give it a chance to work.
yeah. As far as high TPO, if you want my 2 cents, well, first of all, we want to make sure that the thyroid function is adequate. We want the free T3 in the upper third of the normal range, so 3.4 to 4.2. We like the TSH between 0.8 and 2.0. Um, we use plant sterolins, which are from the fat of plant, and they actually act like Pac-Man in your system, and will decrease the thyroid antibodies by about 50% within a year. And so if you're not too high from normal, you're are, you're so the one lab 0 to 9 is normal. The other lab, the big lab, is 0 to 34. So if they're the 0 to 9 is about 12 or 13 or 15, we can usually take care of that pretty quickly. The So somebody asked an example of plant sterolins. We use Mojo, usually twice a day. And there's a number of different companies that makes it. Do I think Hashimoto's has increased as a result of COVID? I don't know. It's rampant around here where we are. I think we were downwind from where all the nuclear testing was done in the 50s, 60s. I think that had something to do with it, at least in where I live. Um, my next line is low dose naltrexone. We use a lot of that. Very low doses though, 0 to 3.0 milligrams. Usually that's the tops. The thyroid's very sensitive to naltrexone, and we usually end up, if they're on thyroid replacement, they usually end up having to decrease it because it will improve thyroid function. The last year or two, we've been following Stefan. He's not on tonight. We've been doing iodine levels, and we find that like he said, we're probably about at least 65% of the patients that we screen for iodine are low. And even if they have autoimmune disease, we will replace it. And that's the next line. Selenium, 200 micrograms twice a day. In the literature, will reduce thyroid antibodies by about 40%. And black cumin seed oil is kind of our another go-to, and that'll decrease the thyroid antibodies by another 15 to 20%. That usually covers it pretty much, and so that's what I do. Okay. The spike protein. What did you have there, Dr. Sammons?
Somebody said, is it, did COVID increase Hashis? And I said, yeah, I think the vaccine as well. There's just something about that spike protein that's caused a lot of endocrine issues. I think there's a lot of autoimmune. I think we've all heard about the white clots, and this kind of thing, strokes, heart attacks, sudden death. But I had quite a few, 2021 to 2023, people with new onset Hashis, new onset diabetes. One of my poor patients, she had just gotten diagnosed with new onset diabetes about 4 to 6 months after she had pretty significant COVID. And she recently passed away from full blown stage 4 cancer, unknown primary, just her whole abdomen was riddled with it. And, just turbo cancer. Like, again, and I'm a little tiny practice, right? My practice is just in Anaheim Hills, a little small subset of Anaheim, greater Anaheim area. And the fact that I see it, it's like if you extrapolate that out to a whole population, we're seeing quite a lot. That spike protein is something else for sure.
Yeah, Dr. Collins writes, teens increase in insulin resistance too, increasing. So, so there's that too.
So when I'm seeing insulin resistance, I'll oftentimes also check a leptin. It's a really good opportunity to talk to our teens about, a keto carnivore / paleo type of nutrition, how important it is for them to implement these lifestyle changes now. I think that and that took me about 13 seconds to verbalize. And sometimes just us verbalizing it rather than relying on mom or dad. Leptin. Yeah, leptin. And so, mom's going to say it, but it's just noise in the background because mom's just quacking. And I know this because I am a physician and I have a lot of knowledge and I still know nothing to my teenage daughters. I know no things. I can't cook. I can't do anything right. So very normal. But I think that if we take that opportunity to advise teens, these are the things you should eat, whole natural foods as they come up out of the earth, the less processed, the better. Cut out gluten, cut out sugar, processed sugars, especially. Ignore the Frappuccino that I'm still continuing to drink from this morning. So doing the best we can, and you'll see that insulin resistance reverse. Also heavier lifting. Again, don't go crazy. Like, you don't need to raise a 14-year-old to be a power lifter or anything, but definitely lifting, strength training, cardio exercise, get them outside and off of screens. And there's nothing more frustrating than we want to take our screens away from our kids and then they have homework on their iPad. So getting them outdoors, getting them out of their hoodies, into a tank top, into a sports bra, go outside. I don't want to see you. Come back when the lights are on. That kind of thing. We will see better insulin sensitivity with these things. And now the American Academy of Pediatrics, as a matter of fact, has actually approved tirzepatide for the use in kids as young as 6. Sadly, it's because our obesity epidemic.
That's great.
It's crazy because the childhood obesity rates are such that we need that tool. But I think from an integrative medicine standpoint, we now know that it's safe to use. So for a lot of my kiddos, I use microdosing. It helps with their inflammation. It helps with tissue recovery. I use it for my volleyball player. I give her like 1.25 milligrams every 2 weeks. It helps her stay like kind of in fighting shape. So she gets better tissue recovery. Her knees don't hurt. Again, volleyball player, so her knees are trashed. So it helps her with that. And it helps her with focus and concentration as well because the brain inflammation goes down. And let's see, abnormal leptin. Again, it's just one more tool to say, hey, we need to eat more protein. So if our leptin is elevated, and they're already exercising and eating well, protein focus, protein before you work out, make sure you're getting, 80 to 100 grams of protein a day. So protein, 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 protein. And that's going to help stabilize that blood sugar. So it's going to keep you from having big peaks and troughs, and it will help with that leptin sensitivity. And then you may want to look at something else, such as water damage building or SIRS, Epstein-Barr. Like there, again, we get into that other netherworld of other kind of chronic inflammatory disease processes that may be triggering a leptin issue or insulin issue, not so much because there's a lifestyle issue, but because their receptors suck. So we're not getting a cellular response because the cell's not reading it. So we make more, right? We keep making insulin because none of the cell receptors are appropriately shaped or what have you. So can be something to think about.
Okay. All right, great. I got the CME credit link there in the chat. And it looks like there's a link, something about 0 Point and new tech and alien bases.
Hello and welcome to Reality Check.
So I don't know what I hit there. Okay. And Dr. Burgess says the Hawaiian push for orgasm is linked to Kundalini. So I know when you asked about present. Thank you for presenting this topic. Those of you that were at our live shows conferences in Reno in 2020 and 2021. If you remember, Monica Jane, our sex therapist, she was always our last speaker, and it was
the way to do it.
It was pretty interesting. We warned the crowd ahead of time if it was going to be uncomfortable for them. So, but we got lots of kudos in the chat here, and thank you. We'll see about getting as many as we can to visit you tomorrow night, Dr. Farshian's group, and again, let us know where you're speaking. You said you're going to be somewhere in November.
Yeah, so I'm thinking about doing the Aesthetic Immersion Fit Expo in November in Vegas. Their very first pilot one is this weekend at the Anaheim Convention Center. I'm not sure if they have a live web link, but I will send that link to you, Dr. Clearfield, and then you can submit it to everybody and, feel free to join in. But they're really cool. They're talking about EMF suits and different, like all full health. So physical health, peptides. I'm going to be speaking about sexual health and wellness. So a number of different topics. It's not just like, oh, it's only peptides or only stem cells or only this or only that. So it's going to be very broad based, which is cool. And they're actually filming a movie that's going to be released in November in Vegas. So that's when premiere is. It's going to be really an awesome wave to ride for sure.
Great. And we have the IV vitamin C conference coming up at the end of October in Clearwater, Florida. We have that one coming up. We're still hoping to be on par for the middle of November, the weekend of November 14th, 13th, 14th, and 15th here in Reno for a live show for at least the locals here if you want to come, and we'll stream that too. We'll expect you to be available for something on that. We'll get you some more information as we nail that down. We got 2 venues we're still strong arming, and then we're going to get that put together. And we're partnering with NOMA, Nevada Osteopathic Medical Association, and the Nevada Homeopathic and Integrative Medicine Association also. So we'll have that coming up. Next week we have Sharon Hausman Cohen, who is a DNA, a genetics expert, and she'll be speaking on genetic stuff. I think she's the medical director in Intelligent DNA XXX, something like that. So you know about that? You know what that, he probably met her somewhere along the line. So that'll be next week. And like again, anybody who has got any type of topic you'd like to bring up, please let me know. If you have anybody that's a speaker that's part of our part of our sphere, let me know. I recruited a couple of students last week at the from Toro for the Nevada Osteopathic Medical Association. I don't know if they were on tonight. If they were, welcome. I'll find out when I get the census later. But they brought a lot of energy. We were a bunch of old fogies there until they showed up, and then all of a sudden the place livened up.
We had a
So,
tsunami warning.
anybody else have any comments or questions? Dr. Quinn, you still there? How's the research group going?
Yeah, I'm still here. Absolutely great lecture. The thing, of course, I like the most about it, she was talking about lifting heavy things for muscle. That's what I'm all about. We had a Benton on Saturday that was pretty much taking up the entire time, and I think he's going to try to get a hold of you, or we're trying to get him connected with you to talk one evening. Very interesting topic. Very interesting.
Okay, great.
That's what we did.
You know where to get me.
Yeah, exactly.
Okay. Tomorrow night, Dr. Sammons will be on with Dr. Farshian's group, and those are our best bros. And on a rather little bit of a sad note, those of you know who Joel Peterson, my right hand man, he's had some health issues, and unfortunately, his father passed away last week. So, if you have his contact, if you don't, send some condolences. So,
yeah, thanks. He was on Saturday.
He was on.
Yeah,
His father passed away Thursday morning. Yeah. So, and on that, I don't know, Dr. Nario, got anything, any questions in the chat or any final comments?
Yeah, there's some interesting comments here. They were saying that they were on the email, they were expecting, oh, we're gonna get some hormone recommendations here. But this is really that's really a big twist that you gave to this topic. That sexuality and hormones does not mean medication, especially when a type of doctor like you who would present it this way. But it sounds like you're focusing more of the non-hormonal psychological aspects of sex, and also it doesn't mean that you have to use testosterone. It has to be you checking all the boxes about psychological connection and even the emotional, spiritual side of everything. So that's why this is actually a good eye opener for everyone there. That sexuality doesn't mean that we're just going to give you testosterone, progesterone, and estrogen. And I see this a lot when I see cancer patients, because cancer patients have a lot of these sexual problems, especially after therapy. As you mentioned, they go through a lot of changes when they do chemotherapy and radiation, and especially body image changes.
Yes.
So majority of these patients actually are so insecure about themselves because of the scars, the surgical procedures that they went through, the weight gain, the weight loss. And this is something that we also address in cancer care. And that's why, as part of the recommendations, vaginal estrogen is something that's recommended even during cancer therapy.
Yes.
For these type of patients to experience sexual connections again, and for them not to be deprived of this right of every human being. So that's why this is, again, a good talk, just putting out there that it's not all about hormones, and there are other people who are benefiting from such discussions, especially for these types of patients.
Yeah, thank you for that. And and certainly, like I said, I have plenty of lecture material and so forth about hormone replacement therapy. I love hormone replacement therapy. But even case in point, not a cancer patient, but I had a paraplegic. She was injured in a car accident. They initially took her off her hormone replacement. She was like in her early 50s, maybe late 40s. Took her off HRT because they were worried about VTE initially after the accident. She'd fractured her spine and whatnot, so she's immobile. Understandable, right? So again, newer evidence says maybe VTA is not increased with HRT, but I think that's a fair removal, right? But since then, she had been unable to get any provider to check her hormone levels. And their answer was, well, you're paralyzed. You're not having sex. Why would we check? And I was just blown away. I'm like, wow, wow. So a sense of vitality and vigor and mental health and overall general health, maintenance of tissue integrity. Even if I'm not going to tell her that hormone replacement therapy is going to get her walking again, I'm not making that claim. But can we preserve the rest of her tissues, please? Or are we just going to watch her slowly decline into nothingness with no interest, no desire? There are other ways to have intercourse than the traditional intercourse of, again, male to female penetration. So there's other ways that we can help augment her quality of life. And the fact that they just wouldn't even look at it, it's very disappointing. So yeah, if we can sort of bring it from a multitude of facets to have patients reach into their whole health, and then again, understand how that sexual health plays into their overall health as well. That's kind of the message I wanted to convey.
Yeah, and if we even have discussions with cancer patients about self-pleasuring, because the oxytocin, the dopamine definitely brings in a lot of healing factors here in relation to, again, in boosting that immune system to fight cancer. So this is a topic that's kind of taboo in society, but we, as us, as being practitioners, being open about these types of discussions kind of makes it more out and being more acceptable to not only society, but also in the medical field. But again, labeling somebody who only has the right for sexual pleasures, for if you have two hands, 2 feet, and a normal looking body, that shouldn't be the stereotype of this discussion. And you would also see that the biases of using hormones when testosterone FDA approval for women is only for I guess libido, low libido, right? Hypogonadism.
Low
That's the
libido
only
or
approval.
transitioning, right? If you're
Right.
transitioning gender.
Right, that too. That's the new one. I mean, that's a new one, not a new one probably. But again, that's just the bias of using testosterone in these populations. Women, they definitely have more benefits in relation to just using it for libido. So even that needs to be changed in the stereotype of society and even the government, that they should understand that as men need testosterone, women, they do as well. Not only in those high doses, as you mentioned, but definitely they need to look into the different aspects to maybe consider FDA approval.
Yeah, absolutely. And it's interesting, you know, I kind of have this joking conversation with my husband all the time. It's like, because he's my sounding board, poor guy. He's an HVAC guy. He's not even in medicine. And, you know, I'm like, so the men that are getting these prescriptions for Viagra and Cialis, who are they having sex with? You know, and 2 20-year-olds is not the same as a 40-year-old, right? So they're having probably intercourse with their age-matched relationship partner who has dyspareunia, a horrible ripping, tearing, recurrent urinary tract infections, her tissues are falling apart, she's got a frozen shoulder, and she can't have hormones, but you can have Viagra all day long. It's like, come on, guys, like let's even the playing field here and make our women back into full health. Men don't lose their testosterone at age 50. They should be reproductive all the way to the grave, right? I mean, Ben Franklin was having kids in his 70s. That's normal. We have a lot of those endocrine disruptors, as I alluded to, so that men's testosterone is much lower. I mean, I see 28-year-olds who have a testosterone level of 270. It's ridiculous. So there are men who have this hypotestosterone production, but it's just so much more than that about testosterone, or excuse me, tissue integrity and wellness and vitality and vigor, which is very hard to quantify. There's no lab test for vitality.
And that's a good sales pitch for your business. If
There
you're
it is.
treating
Did
the
somebody
woman,
record that so I can put it
yeah,
up on the?
We have it. It is recorded.
yeah, if you're treating the women, get the husbands in there so they can catch up with this too. So it has always to be a pair because they're going to leave the other one behind. You don't want to be the one left behind.
Oh, 100%.
So
Yes.
you can go on YouTube and see my 7 minutes at the Androgen Society on that they gave me for testosterone for women's clinical applications. I got 7 minutes.
I love it.
And
Enough.
it's on our YouTube channel. So
7 minutes is enough for an office visit, right? So that's
well, yeah, plenty. um, so with this person that I'm sure you were the one who did all her hormones and started balancing them out then?
Yes.
Because
Yes.
I was going to say, if you said you couldn't find anybody to do it, send them to us. Dr. Nario and I will take care of it.
Oh, for sure. For sure. No, I'm not shy about it, but I love having this forum where we can have these conversations together and shoot problem patients off each other and say, what would you do? You know, I think that's so important.
Mhm.
You'd be
Okay.
surprised. I'm having conversation about lubricants and vibrators with patients. Sometimes I
I
get
know.
myself my own education. Like, really, there's something as such. Give me
Yeah.
a notebook. I'll write it down.
Oh yeah, for sure. No, the things I learned from patients is just remarkable. So I learned this one from patients. I don't know if you've heard of this tip. So with the estradiol patch or any like topical patch, if you have sort of a site reaction to the adhesive, you can spray Flonase because it's just fluticasone. It's a little topical steroid. Spray it on half hour before and then apply your patch and you won't have the reaction. Get out of town. One of my patients taught me that. I'm like, what? Because she loved her patch, but she was having a little redness, and so fixed it right up. I'm like, oh, okay.
Yeah, I always remember, I think I've told you, Dr. Nario, my first anti-aging patient. I'd gone to my first A4M weekend, and when I came back, I was, big stuff. I knew everything that there was to know. And, we lived in a small town, and somehow it got around. So this lady came, she was 58 years old, and she told me I had to fix her because she was getting married to a 40-year-old. And we had to get her in shape so she could keep up with him.
Love that. I love
So I
that.
don't even. This was like in 2003, I think, or 2004. I don't even remember. Couldn't even tell you what we did. I'm sure it's nothing like what we would do today. And she came back a couple of 6 weeks later, and she was okay. And then I didn't see her for about a year and a half. And she came back, and she looked like death warmed over. And I said to her, "So what happened?" She goes, "It was no good from the start. On our wedding night, he made me throw my toys away." And it's like I
Oh,
was
no.
I'm holding my ears and I'm saying, "Mom, you didn't hear that."
Yeah. La, 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 la.
If my mother knew what I did for a living, she would have said I
100%. Yeah, that's red flag central. Absolutely
Yeah.
not.
Touch
So
everything, not her toys.
that was 2003, and I still remember that one. That's one of those ones you don't forget.
Oh, absolutely. My goodness.
So, okay. Anybody else? Dr. Hapnary, got any others there, or
No, that's it. I'll just get
that's
a
it?
speaker
Okay.
for our toys.
Okay.
Now you gave me some ideas.
Now I got you some ideas. Okay. All right. Okay, everybody. Thank you so much. Thank you, Dr. Sammons, as always. We'll see you again tomorrow night. And we will definitely have you back. I always say that if you're competent and if we ask you back, if you're no good at it, we don't call again. So
Well, I appreciate
it's
that.
like
Thank you.
it's like anybody who has any yard work or fix something around the house. I only get asked once.
Yeah.
I never get asked the second time. So,
That's the trick. You want to do it poorly enough, they never ask again. Yep.
right. All right, everybody. Great talk, and thank you all for your participation and your interest. Please bring one friend so we can keep growing our little group here. And think about we'll try and get nail down the venue and start populating for a live show in November. Okay. Um, and that's about it. Anybody else have any comments or questions? We'll pick it up. See you again next week with Dr. Cohen.
Thank you.
Okay,
Yeah.
thank you all.
Thank you.
Thank you.